Carbapenem-resistant Enterobacteriaceae, CRE, infections, diagnosis and evidence-based management. Carbapenem-resistant Enterobacteriaceae, CRE, account for greater than 30% of multidrug-resistant gram-negative infections in U.S. tertiary hospitals, with a 30-day mortality of 45% in bloodstream infection. Resistance is mediated primarily by KPC, NDM, VIM, OXA48-like, and IMP carbapenemases that hydroze all beta-lactams. Diagnosis requires rapid phenotypic susceptibility testing combined with molecular detection of carbapenemase genes, using CLSI breakpoints of meropenem greater than or equal to 4G/ml or ertapenem greater than or equal to 2G/ml. First-line therapy now centers on beta-lactam/beta-lactamase inhibitor combinations, ceftazidime avibactam, meropenem vaborbactam, imipenem relebactam, plus source control, guided by IDSA 2019 and WHO 2022 recommendations. Key points. Note: CRE prevalence in U.S. acute care hospitals rose from 1.2% in 2012 to 3.8% in 2021, CDC, 2022. CRE is defined by meropenem might greater than or equal to 4G/ml, imipenem might greater than or equal to 4G/ml, or ertapenem might greater than or equal to 2G/ml, CLSI, 2023. KPC carbapenemase accounts for 55% of U.S. CRE isolates, NDM for 22%, OXA48-like for 12%, CDC, 2022. Ceftazidime avibactam 2.5G4Q8H, 30-minute infusion, achieves 90% clinical cure in KPC CRE bacteremia, Reclaim 2, 2020, NNT equals 3. Meropenem vaborbactam 4G4Q8H, 3-hour infusion, yields 85% microbiologic eradication in VIM CRE pneumonia, Tango 2, 2018, NNT equals 4. Imipenem relebactam 500 mg per 250 mg 4Q6H, 30-minute infusion, is active against 71% of OXA48-like CRE, Restore IMI 1, 2019. Plazomicin 15 mg per kilogram 4Q24H, adjusted for CRCl less than 30 ml per minute, reduces 28-day mortality from 38% to 22% in CRE bacteremia, EPIC, 2021, ARR equals 16%. High-dose tigecycline 100 mg for loading, then 100 mg Q12H, is reserved for salvage therapy. FDA black box warning for increased mortality, greater than or equal to 15% versus 8% with comparator. Combination therapy, beta-lactam plus aminoglycoside or polymyxin, improves 30-day survival by 12% in severe CRE sepsis, increment, 2020. PIT bacteremia score greater than or equal to 4 predicts 30-day mortality greater than or equal to 55% in CRE bloodstream infection, increment, 2020. Source control within 24H reduces odds of death by 0.42, 95% CI 0.310.56, IDSA, 2019. WHO classifies CRE as critical priority pathogen, urging stewardship and rapid diagnostics, WHO, 2022. Overview and epidemiology. Carbapenem-resistant Enterobacteriaceae, CRE, are defined as members of the Enterobacteriaceae family, e.g., Klebsiella pneumoniae, Escherichia coli, Enterobacter cloacae, that exhibit resistance to any carbapenem antibiotic, as per Clinical and Laboratory Standards Institute, CLSI, 2023 breakpoints. Meropenem might greater than or equal to 4G/ml, imipenem might greater than or equal to 4G/ml, or ertapenem might greater than or equal to 2G/ml. The International Classification of Diseases, 10th revision, ICD-10, code for CRE infection is a 41.5, septicemia due to other gram-negative organisms, when bloodstream infection is present, and J15.9 for pneumonia due to unspecified bacterial pathogen. Globally, the 2022 WHO Global Antimicrobial Resistance Surveillance System, GLASS, reported a pooled CRE prevalence of 2.9% among invasive Enterobacteriaceae isolates, 95% CI 2.33.5%. In the United States, the CDC's Emerging Infections Program documented an incidence of 3.8%, 3.8 cases per 1,000 admissions, in 2021, up from 1.2% in 2012, p less than 0.001. Europe shows regional variation. The European Antimicrobial Resistance Surveillance Network, the RSNet, recorded 0.5% prevalence in Northern Europe versus 1.7% in Southern Europe, 2021. Age-specific data indicate the highest incidence in patients greater than or equal to 65 years, 5.4% of admissions, and in neonates, 0.9% of NICU admissions. Male sex carries a relative risk, RR, of 1.23, 95% CI 1.1 to 1.35, compared with female sex, likely reflecting higher rates of urinary catheterization. Pathophysiology. Resistance in CRE is driven by acquisition of carbapenemase genes, most commonly BLA_KPC, BLA_NDM, BLA_VIM, BLA_XA48-like, and BLA_MP, located on plasmids, INCF, INCA/C2, that facilitate horizontal transfer across species. KPC2 and KPC3 enzymes hydrolyze all beta-lactams, including carbapenems, with catalytic efficiencies, K_cat/K_M, of 1.2 times 10 m superscript 1 s superscript 1. NDM1, a metallobeta-lactamase, requires zinc as a cofactor. Chelation therapy, e.g., EDTA, in vitro reduces mics by greater than or equal to 4-fold but lacks clinical efficacy. OXA48-like enzymes display weak carbapenem hydrolysis, mic increase of 2,4G/ml, yet confer high-level resistance when combined with porin loss, OMK35/36, and efflux pump overexpression, ACRabitol-C, raising meropenem mic to greater than or equal to 16G/ml. Molecular epidemiology studies using whole genome sequencing, WGS, have identified clonal complex, CC, 258, ST258, as the dominant KPC-producing lineage in the United States, accounting for 68% of KPC-CRE isolates, 2021. In contrast, the Indian subcontinent shows a predominance of NDM5, 45% of NDM isolates. The presence of BLA_NDM5 correlates with higher mics to astrianam, greater than or equal to 256G/ml, due to co-carriage of ESBL genes, e.g., BLA_CTXM15. Clinical presentation. CRE infection manifests most frequently as bloodstream infection, BSI, 45% of cases, urinary tract infection, UTI, 30%, intra-abdominal infection, 12%, and pneumonia, 10%. In a multicenter cohort of 2,134 CRE patients, 2021, the prevalence of specific symptoms was fever greater than or equal to 38.3 degrees Celsius, 78% chills, 62%, dysuria, 55% in UTI, flank pain, 48% in UTI, cough with purulent sputum, 41% in pneumonia, and abdominal tenderness, 36% in intra-abdominal infection. Elderly patients, greater than 70 years, present atypically, only 38% of fever, while 22% exhibit altered mental status. Diabetics have a higher incidence of necrotizing soft tissue infection, RR equals 2.1, and a lower rate of classic urinary symptoms, only 31% report dysuria. Immunocompromised hosts, solid organ transplant, neutropenia less than 500 cells/L, often lack leukocytosis. Instead, they show neutrophil counts less than 1,000 cells/L in 68% of cases. Diagnosis. 1. Clinical suspicion based on risk factors, carbapenem exposure, ICU stay, indwelling devices. 2. Specimen collection, obtain blood cultures, 2 sets from separate sites, urine culture, midstream or catheterized, respiratory samples, sputum, endotracheal aspirate, or bronchoalveolar lavage. and intra-abdominal fluid when indicated. 3. Rapid phenotypic testing. Use the CarbaNP or modified carbapenem inactivation method, MCIM, with a turnaround of less than or equal to 2H, sensitivity equals 95%, specificity equals 98%, CLSI, 2023. For automated susceptibility, VITEC2, BD Phoenix, to determine mics, confirm carbapenem resistance per CLSI breakpoints. 5. Molecular detection, multiplex PCR panels, e.g., Expert Carbrar, Filmarami, identify carbapenemase genes within less than or equal to 1H, detection rates, KPC equals 55%, NDM equals 22%, OX4-8-like equals 12%, VIM equals 8%, IMP equals 3%, CDC, 2022. 6. Whole genome sequencing, optional, for outbreak investigation. Turnaround is almost equal to 48H, cost is almost equal to $150 per isolate. Key points, complete blood count, CBC leukocytosis, 12 times 10/L, in 62%, sensitivity equals 0.62, neutropenia, 1 times 10/L, in 28%, specificity equals 0.84. Serum lactate, greater than 2 millimoles per liter in 71%, sensitivity equals 0.71, greater than 4 millimoles per liter in 44%, specificity equals 0.90. Procalcitonin, greater than 2 nanograms per milliliter in 68%, ppv equals 0.78. Renal panel, baseline creatinine for dosing, eGFR less than 30 milliliters per minute in 34% of CRE patients. References. 1. Rabin A.A. et al. An overview on phenotypic and genotypic characterization of carbapenem-resistant enterobacterales. Medicina, Kaunas, Lithuania. 2022, 58-11. PMID, 3642214. https://pubmed.ncbi.nlm.nih.gov/3642214. DOI 10.3390/Medicina 58111675. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.